I have visited hospitals many times in our state. In fact, there's 128 community hospitals in Kansas, and I have visited each and every one of them once, and in many instances 2 or 3 times. In fact, just last weekend while I was home in Kansas, I visited my hometown hospital, Mercy, in Manhattan, Kansas. And it's a very useful exercise. I would encourage my colleagues to spend time with healthcare providers. In the case of hospitals, it gives you the opportunity to visit with hospital administrators, the CEOs, the opportunity to visit with nurses and patients, with physicians, and get a feel for what's going on in the delivery of healthcare in your state. I certainly know how valuable that is to me. One of the interests I have in serving in Congress is a belief that the way we live our lives at home in Kansas is something very special, and it's something that is worth trying to make certain is around for many years to come, in fact, for generations to come. And one of my early conclusions in looking at public policy and looking at the future of the communities of Kansas and the people who live there is the access to health care, to affordable health care, is critical. It's a component in which many communities will not continue to exist if there's not access to hospital care, physician, hometown pharmacy, all the things that make up the opportunity for someone to be cared for in every aspect of their lives related to their health. I know this in my own circumstance, my hometown population, my hometown of Plainville population, about 2,000. My parents called Plainville home into their 90s. My parents are no longer living, but I know well before the time in which they passed, my sister and I would have had a conversation with my parents talking about, Mom, Dad, I'm sorry, but you need to move, and you need to move where you can have adequate health care. You need to move where there's a good hospital and a set of physicians who will care for you. But because that exists in my hometown and continues to exist in my hometown, those kind of conversations are not necessary. And wherever the place that you're telling your parents they have to move to access health care, whatever that place is, and it may be a very, very desirable place, but it's not home. My parents would have lived someplace in which they had not lived almost all of their lives, would not have been surrounded by the people who they know and know them. And particularly as they lived, my dad, until the age of 98, they did not have the people who checked in on them, made sure they were doing okay each and every day, gave them the opportunity to continue to live at home. The people who would have given them a hug and a pat, the pharmacist who would have asked my dad, Ray, you probably need to have your blood pressure taken. Those are pretty special things about the places that many of us come. And in the absence of those kind of opportunities for health care, our communities, certainly across my state, but around the country, and especially in rural America, began to disappear. So the point being that in the absence of access to health care, the ability to keep a community together, to encourage senior citizens to remain at home in their hometowns, and for us to be able to recruit and encourage young families to move to our communities, not going to happen, not going to be available unless we have access to health care. The discussions I have with those healthcare providers, the doctors, the nurses, the CEOs, the administrators of the hospital, including the patients, they continue to remind me that the things that are going on in our nation's capital, here in Congress, and certainly in the administration, are barriers, are burdens to the chances of that hospital and those healthcare providers continuing to be in business. Every visit involves the raising of concerns to me. Often it's, what are you doing about this, Senator Moran? What are you doing to reduce the federal regulatory burden that our hospital faces? And are you working to make certain that we're able to provide the health care that our local residents need? Just last month, I introduced legislation that was bipartisan, a resolution that unanimously passed the Senate. It recognized the importance of access to hospitals and other health care providers, particularly in rural areas of our country, indicated how essential they were and how important they were to the success and survival of the communities here in our country. And the point I would make about that resolution, it passed unanimously. And while the importance of rural providers is overwhelmingly acknowledged, as evidenced by the unanimous passage of that resolution, The Affordable Care Act and unnecessarily burdensome federal regulations fail to demonstrate that we follow through on that understanding of the importance of hometown health care. Among the regulatory concerns that I hear about in those hospital visits, serious flaws with what's called RAC, the Medicare Recovery Audit Contractor Program. It's causing major problems for many hospitals and providers across Kansas. Our hospitals, healthcare providers have been required to divert significant resources away from caring for patients, their mission, to appeal incorrect audit decisions that are almost always ultimately overturned through an appeals process. This broken RAC program places a tremendous burden on the providers, and it's created a 2-year appeal in backlogs within the Department of Health and Human Services. This program diverts the resources that hospitals are devoting to caring for patients to going through the process of trying to get their money back. And that's certainly a problem in increasing the expense of providing health care. But the other aspect of that is often the hospital's money is tied up for 2 years, held by CMS, the Center for Medicare and Medicaid Services, while it's adjudicated. And again, the overwhelming number of cases are ultimately decided in favor of the hospital, but it's certainly diverting resources and increasing costs. I've met with the Secretary Burwell at Health and Human Services to discuss what is an urgent need to improve the Medicare RAC program. And I've requested from HHS a timeline and objectives, measurable objectives, to address the RAC problems and the backlog the appeals backlog that's in existence now. Another concern, in addition to the RAC audits, is the federal government's inflexible physician supervision rules. CMS passed a rule that was delayed but now ultimately put in place, and it requires that many pretty routine services that occur at a hospital, including things like a drug infusion or blood transfusions, cardiac and pulmonary rehabilitation, that it requires physician supervision. And that's just not an option in many rural healthcare hospital settings. There's a lack of understanding, a lack of common sense as to what a small hospital in a small town faces when CMS puts this regulation in place. They make it difficult for those hospitals to continue to provide those necessary services. And fortunately, we've had some success in addressing this issue. Congress passed legislation that prevents the federal government from enforcing that regulation through the near future. I've introduced original legislation to make that change, that regulatory prohibition, permanent, and I will reintroduce that legislation in January in the new Congress as we try to capitalize upon the temporary success we have had in fighting back this regulation from CMS to make it permanent, that they don't, when the temporary prohibition expires, that we will have the opportunity to keep them from reintroducing that position. I would tell you that hospital administrators and employees, when you have a conversation with them, the discussion typically involves serious and strong opposition to a number of proposals that come from the Obama administration each year. One of those is to change the number of miles that you must be apart from another hospital in order to qualify to be a critical access hospital. That's a program under Medicare and Medicaid services that allows for a reimbursement that's more based upon cost than otherwise would be the case. And also, the administration has continued to propose a 1% reduction in the funding for those critical access hospitals. Those are pretty much life and blood issues for community hospitals across Kansas and around the country. That critical access hospital designation, in receiving that cost-based reimbursement, means that a hospital with few patients, one that doesn't have hundreds of patients each day, can still be reimbursed at a rate in which they can almost make ends meet, that they can cover their costs, but still rarely is there any profit or extra revenue generated from that so-called cost-based reimbursement. Cutting reimbursements to the hospitals, removing them from the critical access program, I have little doubt but what it would eliminate many, if not most, of those hospitals currently in that critical access hospital program, and there would be no place else for them to go, no other category within Medicare that would allow them to survive. And I believe the number now is 88 of Kansas's 128 hospitals are those critical access hospitals. One of the other topics of conversation that arise in those conversations in visiting with healthcare providers at a hospital, the physician, the nurses, the physical therapist, the CEO of the hospital, the trustees, the board of directors of the hospital, is the Affordable Care Act. Again, we symbolically say we care a lot about rural healthcare providers, but the reality is the Affordable Care Act is creating significant problems, challenges for the survival of hospitals, particularly our smallest hospitals in my state and across the country. The Kansas Hospital Association projects that the Affordable Care Act will cost Kansas health care providers approximately $1.3 billion in Medicare funding over the next 10 years. The Affordable Care Act cuts include reductions to hospitals' Medicare reimbursements and a program called, or a payment called disproportionate share that they receive, the hospital receives in order to cover the high level of uninsured patients. And these cuts are taking place on top of what Congress and the President agreed to under sequestration, a 2% across-the-board cut that many, if not all of our providers are now receiving. So what was supposed to be cost-based reimbursement is already being, which nearly never covered the costs, is being reduced by another 2% as a result of sequestration. Again, something that this Congress, and if not this Congress, the new Congress that begins in January, needs to deal with the issue of sequestration. For this and for other reasons, sequestration is a significant problem. And while I certainly support the reduced spending aspects, what the goal was of sequestration, the idea that we would do across-the-board cuts is irresponsible. We ought to be establishing the priorities, the things that Congress, on behalf of the American people, think is the most important and beneficial to the American people, the things that are allowed for under our Constitution. Those are the things that we ought to be funding, as compared to really taking a step back and saying just automatic cuts because we don't have the ability to decide in a responsible way what we can afford and what we cannot afford. Further, I would say that the Affordable Care Act forced states to adopt, the original act, as passed by Congress, required the states to adopt an expansion of Medicaid. The United States Supreme Court, in its 2012 ruling, indicated that Medicaid expansion was optional, not mandatory, under the Constitution. And so that portion of the Affordable Care Act was determined to be unconstitutional. And states are now faced with the difficult decision that involves Medicaid and long-term costs associated with potential expansions. And hospitals face tremendous uncertainty about how they will care for an increased number of patients while they are already absorbing the Affordable Care Act's Medicare cuts. And so states are struggling to figure out what to do about expansion of Medicaid. Hospitals are suffering from the consequence of not having additional Medicaid dollars, and that's on top of the cuts that occur as a result of changes in Medicare. Really, in most hospitals across my state, two components are so important. Medicaid and Medicare cover a significant portion of the number of patients that are admitted to a hospital, and in many instances, there are not many private pay patients who have their own health insurance to add additional revenue to the hospital's revenue stream. This scenario of Medicare and Medicaid both creating problems, being squeezed from both programs, presents significant problems for rural hospitals. And again, those reimbursements, Medicare and Medicaid, make up about 60% of those hospitals' revenues. The Affordable Care Act also put hospitals in the difficult position of having to balance increasing regulatory burden with reduced revenues. So in addition to the Medicare, Medicaid pressure, you also have this problem of increasing costs associated with more and more regulations emanating from the Department of Health and Human Services and other places across the federal government at the same time that the reimbursement rates are declining. So increased costs, reduced revenue, again, a significant problem. In 2011, the average Medicare margin for hospitals in Kansas was a negative, not enough to cover the cost, 4.9%. These losses have to be offset somewhere, and that often results in a reduction in staffing. It sometimes means reduction of services, and the end result is a hospital that is not always able to meet the needs of their citizens, their patients. So, and in many instances, it's the hospital that may be among the largest employers in a county or community in our state. And in addition to reduced staffing and inability to buy equipment and to reduce certain specialty programs offered at the hospital, we are also seeing a significant depletion in their cash reserves and a freeze on capital expenditures. These circumstances just not sustainable, and we're seeing hospitals close. Since about 1990, the number of rural hospitals across the country has remained stable at around 2,000, but last year, 15 rural hospitals closed, and we have to be concerned that there are more to follow. This is an alarming trend. These hospitals play a vital role in health care. As I say to those rural communities, it can determine whether or not a community has a future, whether or not individuals and families will decide to live there. And the loss of a hospital has huge ripple effects, and it harms patients. And their primary purpose is to save lives and improve health care, but it also has a tremendous loss to the community itself. I've outlined problems that I believed would occur with the passage of Obamacare on hospitals long before the law became law. I also would say it doesn't mean that I don't believe that there are significant improvements that can be made to our healthcare delivery system, but I think the reality is that the Affordable Care Act causes more problems, significantly more problems than those it solves. Many Kansas hospitals struggle to meet the aging population in their states, and the Affordable Care Act cuts are an exacerbation of their circumstance. Again, the Affordable Care Act, which the promise, I guess, was made that if you like your plan, you can keep it. Your health insurance plan, you can keep it. If you like your physician, you can keep him or her. But one of the consequences, and that didn't turn out to be true, and in fact, if you liked your policy, you're probably not able to keep it, and you've got something else now, and that something else, that other policy, that replacement policy, often involves increased co-payments and deductibles. And that's certainly a problem for the policy holder and his or her family. It's a problem for the business and their employees. But we may have forgotten it's a huge problem for the healthcare provider. Almost every hospital I have visited, now that the Affordable Care Act is being implemented, will tell me about the increasing amount of unpaid hospital bills. The amount of money that's owed that is attempting to be recovered. And the reason that occurs is because the co-payments and deductibles are so significantly higher that patients don't have the ability to pay a $5,000 co-payment or even a $1,000 co-payment. And so the hospital's bad debt is increasing because patients don't have the necessary amount of money to pay for their portion of what their health care insurance policy now requires of them. Again, this comes from a law that was described to us as going to increase the affordability and the availability of health care. And I guess what I would point out is in the circumstance that we're now in, the policies are so expensive, so much more costly, both in premiums and co-payments and deductibles, that the affordability is a problem. Again, not just for the patient, not for the policyholder, but for the hospital who is now left holding the bag because so many of their patients can't pay the co-payments or deductibles. The Affordable Care Act, when it passed, the President's own chief Medicare actuary noted that the Affordable Care Act cuts will cause as many as 15% of hospitals, skilled nursing facilities, and home health agencies to become unprofitable by 2019. And while that, at that point in time, may have seemed like a long time ago, 2019 is now just about 5 years away. And the longer that Obamacare remains in place, the estimated percentage of unprofitable providers is projected to increase roughly, to reach roughly 25% in 2030 and 40% in 2050. So in 2040, 25% of the hospitals, healthcare providers will be unprofitable, and by 2050, nearly half of the healthcare providers will be unprofitable. Again, and particularly in rural communities, if you can't make it on the revenues that come from patients, from providing health care to individuals, often the option is to increase taxes, property taxes, sales tax, something to keep your hospital doors open. And that ought not be the consequence of legislation passed by Congress, is to require the taxes to be raised for a federal program called Medicare because it's failing to meet the needs of American citizens, our patients. These providers, our hospitals, just simply can't sustain the circumstance they find themselves in. And the Affordable Care Act has put us on a path that I think is dangerous for individuals, for businesses, and now for the healthcare providers themselves. In addition to the bad debt experience, many of the new healthcare plans, they have limited or restricted provider networks so that a patient in a particular community may be eliminated, the local hospital may be eliminated from their network, meaning that while previously under their previous insurance policy, they could see a hometown physician or be admitted to their hometown hospital, because of these network restrictions, they must go someplace out of town to access health care. Again, a terrible consequence for the individual, for the patient, but also something that drives revenues away from the hometown provider, much to the detriment of everybody who would want to make certain that that provider, that doctor, remains in the community and the hospital doors remain open. Lots of evidence that the problems that we're facing are real. They demand attention, and access to affordable health care is something that still deserves our attention. And I look forward to trying to make certain that we have that opportunity. Again, that is nothing that's going to happen in the next few days, but we have a responsibility to see that the things that are reducing the access to health care, reducing the access to affordable health care are addressed, and the efforts that resulted from the Affordable Care Act are exacerbating the problem, not solving the problem. With a new Congress soon beginning, I look at elections as like a New Year's. There's this optimism that maybe something good can come from a new Congress, that we can establish our New Year's resolutions and we can begin working. And I certainly make the offer to my colleagues throughout the Senate, all 99 of my colleagues, to be someone who wants to be problem solving, oriented toward finding solutions, and working together to make sure that those healthcare providers that are so important to our lives, our safety, to our health, are around for a long time to come. And the communities that depend upon those hospitals, those 128 hospitals in my home state, have a viable future. We've got to get the regulatory environment under control. We've got to resolve the problems created by the Affordable Care Act, and we need to make certain that health care is an opportunity for people who live in places across my state to still have the opportunity to see the hometown physician, to have a prescription prescribed by the hometown pharmacist, and to make certain that those hometown hospital doors remain open for today and for future generations of communities across my state. Mr. President, I appreciate the opportunity to address the Senate this afternoon, and I note the absence of a quorum.
Clerk will call the roll.